this talk, I'm going to review, very briefly mention the pathologies you might get in the middle ear. Then I'm going to go through why we really do a CT report, because I think often, a lot of clinicians often they don't read our reports. I think we need to make our reports accurate, and I'm just going to highlight why. About 9 minutes of the talk is on anatomy, so the whole anatomy of the middle ear. So there are various parts of the middle ear which I'll go through. Some of them will be familiar, some will be less familiar. The common pathologies, I'm going to show just 4 common pathologies, because again, you're not likely to see a whole spectrum unless you're doing it sort of full time or seeing a lot of cases. And finally, I'm just going to go through 3 cases of how I would report the CT. So CT is the most common imaging modality. If you have a patient who's had surgery for cholesteatoma, and there's some concern about residual or recurrent disease, then you might want to do a non-echoplanar imaging diffusion. So depending on your scanner, HASTE or Propeller or various other scanners. So this list of pathology is deliberately a little bit busy. It's basically a surgical sieve. This list is available on Google or books anywhere. I think the main thing that I'd like to highlight is the common things that people will see are otitis media, so either acute or chronic, so AOM, COM, and cholesteatoma. And of course, cholesteatoma is often associated with otitis media. Trauma was quite common, and out of the tumours, glomus tympanicum is the one that you might see most commonly. And then again, off that list, the ones you don't want to miss. If your surgeon isn't aware that this blob in the middle ear is a vascular structure, there's a risk of bleeding and stroke. So those are the ones you don't want to miss, and the rest, you may see occasionally. So the useful thing about the middle ear, the ENT surgeon can see most of the middle ear, and in an ideal world, you would have a decent clinical history on the request, examination findings, and you obviously know the age. And the combination of those 3, really for the middle ear, should really guide your differential diagnosis. So a patient with discharge, it's likely to be otomastoiditis plus or minus cholesteatoma. If you've got pulsatile tinnitus, it's going to be either a vascular lesion, such as a glomus tympanicum. So I think the new terminology, preferred terminology, is paraganglioma, or an aberrant ICA. And if you think that the CT isn't adequate for actually diagnosing the lesion, you should go on to do further imaging. So most commonly, a post-contrast MRI head, or if you've got pulsatile tinnitus, usually a CTA, to look for a vascular abnormality. So temporal bone anatomy, this is the whole temporal bone. It's pretty complex, and it has undergone 350 million years of evolution, so says Peter Somm. So the purpose, I think, of the CT report, the ENT surgeon has seen something, and he or she has got an idea of what's going on. So you want to confirm or refute what they have found. And I think it's really important to provide an accurate map of disease, including the blind spots. So the ENT surgeons know their anatomy. We need to know our anatomy equally as well, or better. And then, of course, advise on further imaging as required. So what are the risks in middle ear surgery? These are the things you need to try and keep in mind when you're reporting. So if you've got a lesion, you want to mention the bony labyrinth. If the bony labyrinth is damaged, either by the surgeon or by disease, you're going to have a dead ear. Facial nerve palsy is obviously quite a significant problem for patients. And if you've got a problem with the roof of the middle ear, the tegmen tympani, then you're likely to have temporal lobe damage. There are cases where you get temporal lobe abscess, foreign bodies. So these 3 structures really are important for the patient. And the other thing that the ENT surgeons commonly encounter when they actually go into the middle ear, there can be damage to the chorda tympani. So the chorda tympani is a branch of the facial nerve. We cannot see it, so I've mentioned it, but it's not something that you're going to report on your CT temporal bones. And the patients often have taste alteration from that. So the next sort of 9 minutes, I think it is all about anatomy. I think if you're going to give a report, I think it's not adequate just to say there's soft tissue in the middle ear. So this is sort of a refresher of anatomy, and it's a little bit dry. I'm going to go through each of the structures. You need to have decent CT. So if you've got a standard CT head with thick sections, no good. Thin sections of the temporal bone, you'll probably find that, like in my department, that you have radiographers who rotate, so your positioning is often, it's not perfect in any plane, to be honest. So it's useful to be able to straighten this on a volume viewer. And you need to scroll through the images, you need to magnify where necessary and compare. And of course, when you've had bilateral mastoidectomy for cholesteatoma, it makes it much more difficult in the middle ear because it's useful to have the normal one side. So I think I'm going to just start with a very basic thing on compartments. If you're going to describe soft tissue, you should give where it is. So if you can draw a horizontal line from the actually, I need a pointer. It's on here. Yeah, sorry. So you draw this horizontal line from the... You go to the external ear canal. This is your central point. If you draw a horizontal line along the roof and a horizontal line along the floor, it gives you your 3 compartments in the coronal plane. So the epitympanum is above the canal, and it's often referred to as the attic. The mesotympanum is at the canal, and the hypotympanum is below. And actually, the hypotympanum is a very shallow little trough, and it can sometimes be almost non-existent and quite hard to see and to differentiate from the mesotympanum. So next, the ossicles. This is a one sent from Google, and you can see how tiny the ossicles are, the tiniest bones in the body. I'm going to go through each of the sort of anatomical parts of each bone, again, as a refresher. On a CT, you're really only going to see mainly the head of the malleus, and then the neck, then the manubrium. And sometimes on an axial, depending on your position, you're going to get a sort of combination of sort of neck and manubrium. And of course, the manubrium, the bottom of it is the attachment to the tympanic membrane. And then this articulates with the incus, or your anvil. And again, on CT, you're actually going to see the whole, you're going to see all of these structures on CT. It's got a head and 3 processes, so short process is pretty tiny, long process and lenticular process. And the lenticular process articulates with the stapes. Now, the long process and the lenticular process have quite a poor blood supply compared to the rest of the ossicles. So if you're going to have ossicular erosion, it's the long process and the lenticular process which are going to be eroded first in disease. And it's usually cholesteatoma if it is eroded. Stapes, again, it has a head. There's also a neck, which is here. It's not labelled. And 2 crurae. I think in the CTs we do now, you can actually see the whole of the stapes. People used to say, can't really see it. But I think if you have thin enough sections, you can. You don't see the foot plate, obviously, because it's sort of onto the oval window. But anyway, those are your ossicles. That's just to show how tiny the stapes actually is. So the stapes foot plate onto the oval window. So yeah, describe the position of pathology. So I'm just going to run through on an axial CT and then a coronal, the ossicles, and keep it hopefully straightforward. So I'm going from top to bottom. So at this level, we're in the attic or epitympanum. And this is the malleus attaching to the tympanic membrane. The malleus is anterior. It doesn't really show very well on here, but so we're cutting through here, and we've got the head of the malleus and the head of the incus, and of course this joint's also got, probably you've heard it, incudomalleolar joint, incudomalleal joint, lots of terminology. The ENT surgeons in our place often use malleoincudal joint. And as you scroll down, you again have the head of both of those, and you're starting to get this ice cream cone. And if you come slightly further more down, you get a decent cone. So this little triangle here, the cone, is the short process. And you won't really see it on any other sequences. It just disappears after that. The next one down, this is the neck of the malleus. So again, anteriorly. And this is the long process of the incus. And you can see this is the head of the stapes, and these are the crurae of the stapes, front and back. I've highlighted the long process of the incus because that is the dot that you want to look for cholesteatoma. So if the posterior dot is missing at the level of the cochlea, then it's eroded. Even if you've got quite marked otitis media, you can still see that dot present in the middle of all of the soft tissue if you look for it, and it's still straightened up. Further down, so you can see that the stapes sort of angles upwards, and you can sort of think, okay, there's some ossicles missing here. Actually, we're just cutting through here at this level. So you've got the manubrium of the malleus, lenticular process here. And finally, again, if you're looking for your two dots, you need to look at the right level. If you're away down here, cutting through down here, and you've only got one ossicle, it's always the malleus, and it heads immediately. So it's quite a linear process. The umbo is where the malleus attaches. So on a coronal, this is going from front to back, and again, it can be a little bit confusing unless you're scrolling through the images. But the head of the malleus is obviously here at the front. As we scroll forward, you've kind of got this kind of looks like a head and neck actually. So the head of the malleus and the neck, that's probably the lateral process actually. And then as you come further forward, you've got this, for the unwary, who might actually think that this is the long process of the incus, but this is still anterior, so it's the still manubrium. The next again slice, where you see it curving around, this is the long process and the lenticular process here, and there's the stapes. And this has been described as a racing car driver. So, if you can imagine that. So the head, this is the racing car head, this is the body, this is the leg pushing onto the sort of foot plate, so here. So the steering wheel here, this tiny little structure below the lateral canal, is the part of the tympanic segment of the facial nerve. So the recesses that I think, the reason I'm mentioning these is these are blind spots for the ENT surgeons. So you need to, in all your reports, mention if these are involved. So to find them, you look for this tiny little bit of bone. It's supposed to be like a pyramid. It doesn't always look like a pyramid. The facial nerve here, this is a facial nerve. This is the pyramidal eminence, and on either side you have recesses. So the one medial is the sinus tympani, and the one lateral is the facial recess. And if you don't mention, if you think they've got cholesteatoma and you don't mention these spaces, then the surgeon may not necessarily dig in or like actually, manoeuvre into those spaces. And they can be very variable. As you come down, you can see that unless you have actually scrolled up and down, this is the facial nerve here, and you've got these recesses either side. And the sinus tympani, as in this case, can be very deep as well. So muscles and ligaments, the tensor tympani, this is really just so you don't, you can differentiate soft tissue or abnormality from a muscle, just to very briefly go through. The eustachian tube opening is here, and this is the eustachian tube here, right next to the ICA. And then the tensor tympani arises lateral to the eustachian tube, innervated by V3, and then it comes forward towards the middle ear, comes forward, and then it turns 90 degrees, and then it inserts onto the neck of the malleus. So that little structure is just worth knowing about. The malleal ligaments, so something that Matt Bull from Frimley Park educated me about at the UKRC this year. Again, it's just to know about the ligaments. There are only 3 ligaments. They all relate to the malleus. On this axial, there's a tiny little ligament here, the anterior one, and then this is the lateral one. So again, just to have heard about them. On the coronal, it's pretty tiny here actually, but they're all tiny structures, which is why you need to magnify. This is the superior malleal ligament, and this is the lateral malleal ligament. So 3 ligaments that... the only really relevance of these actually, if you've got a patient with conductive hearing loss, so you need to, and you see some linear calcification, then that suggests that you've got ligamentous fibrosis or calcification, which is producing conductive hearing loss. So that's really the relevance of those ligaments. Stapedius, again, just to point out, this is the pyramidal eminence, and the stapedius is here. It's absolutely minuscule, and it attaches to the stapes. So if you see that, it's got a different innervation, the facial nerve. And of course, both the tensor tympani and the stapedius are there to protect your inner ear from loud noises. The windows, very briefly, we've talked about the oval window. If this is the stapes here, this is the oval window. And the round window is the sort of exit for the sound energy. And again, how to find it? Well, most people have no idea how to find it. So if you find the basal turn of the cochlea here, and then go to its lateral aspect, this is the round window here. And then the importance of this, if you are someone who does cochlear implant CT reporting, the white arrow here, again, is highly magnified. This is the oval window, this is a round window, and this is a round window niche. Now, this is the route of insertion for a cochlear implant, so it goes through here. So you need to mention if there's disease in the round window niche as well. The tympanic membrane, a lot of people wonder about the words that are bandied around, pars flaccida, pars tensa. The pars flaccida is basically at the top, and it's pretty small, and the pars tensa is the rest of the tympanic membrane. This is the schematic of the malleus. So when you hear about cholesteatoma, you're talking the top and the front. Tegmen tympani, again, this is just the roof of the middle ear, so it's here, and you need to use the coronal. And this is obviously the inferior temporal lobe, or the middle fossa. And if you've got a defect here and you've got an encephalocele, then you should do some thin section coronal MRI, usually T1 and T2, to look for, to assess the encephalocele better. The scutum, again, is a coronal structure. It's here. It should have a very sharp contour. And if it's eroded, this is where I mentioned the pars flaccida cholesteatoma. It starts most commonly here. And finally, Prussack space, again, something that you should mention in your report if you think there's cholesteatoma. So you find Prussack space, you find the malleus, find a little bust, and you find the scutum, and it's this little space in here, lateral to the neck of the malleus, and it's medial to the pars flaccida, which is here. And it's a common site of cholesteatoma. If you have a low-lying middle cranial fossa, it's not actually that uncommon. The tegmen can be actually sort of hanging down in some patients, and it's something that you need to mention to your ENT surgeon because they're at risk of damage to their temporal lobe in middle ear surgery. I think I've not got an amber light yet, so the 4 common pathologies I'm going to show you are things I think you're likely to see. I'm just going to run through those. Trauma. You need to mention the ossicular chain if it's disrupted. The incudo-malleal joint is the most likely joint to be disrupted. The classification that our ENT surgeons now use is the trauma sparing or violating the otic capsule. So if you have otic capsule involvement, you are going to have a higher risk of quite significant complications, so facial palsy, CSF leak, hearing loss, and subarachnoid hemorrhage, and basically brain bleeding. So in this case, there is soft tissue in the middle ear. There's a fracture through the anterior wall of the mesotympanum. The fracture line extends posteriorly into the otic capsule. So the otic capsule is bone surrounding the labyrinth, and it's the densest bone in the body. Makes fractures a bit easier to see. And of course, it protects the bony labyrinth so you don't become dizzy. So fracture extends here to the basal turn of the cochlea and then out onto the sort of posterior petrous face here. So there is otic capsule involvement. And in trauma, you can also get air, so pneumolabyrinth within the cochlea. Glomus tympanicum tends to be quite a well-defined lesion as opposed to inflammatory changes. It's usually along the course of a branch of the glossopharyngeal, so Jacobson's nerve or tympanic nerve. And usually there's no bony erosion, so the otic capsule is usually intact. And if it's centred on the cochlear promontory, so the cochlear promontory is really just the bone overlying the cochlea, that's classic for a glomus. And of course, in those patients, you're going to have a history of pulsatile tinnitus. They can extend inferiorly. If they extend inferiorly, they can be surrounding the ICA or the jugular. And if in your report, you should describe the relationship of the lesion to the vessels. So this is the one I said you shouldn't miss. If you've got a tubular structure, and I'm actually showing a CTA here, but if you have a non-contrast CT where you have a tubular structure running along from front to back, this should really make you think of an aberrant vessel. And it's often smaller than the other side. So I'm going to just finish with just 3 cases of what I would put in my CT report. So this is the first case. Again, highly magnified. So the middle ear is opacified. The sinus tympani medially and the facial nerve recess are also involved. The ossicles, malleus, long process of incus, and you can even see the stapes here amongst all this disease are intact, and there's no fistulization. In other words, no otic capsule involvement. So I would say this is likely inflammatory in etiology or otitis media. Case 2, this is a coronal, and clinically, the ENT surgeon has put on his report probable cholesteatoma. It looks pearly, it looks shiny to the ENT surgeon. So I would say in this case, again, I would give the compartment. So there's soft tissue in the mesotympanum here, extending into the epitympanum, surrounding the neck of the cruri, the neck and cruri of the stapes, medial to the long process of the incus, and Prussack's space here is clear. And I would say, in this case, in keeping with the cholesteatoma, this is probably an early cholesteatoma because the ossicles are actually intact. Later on, those would be eroded. And the final case is somebody, so a lot of patients come along who've had surgery. This demonstrates, I would mention where the soft tissue is. So post-surgical cavity, there's soft tissue. There's soft tissue filling the middle ear. Soft tissue extending close to the genu of the facial nerve, which I think Dr. Summers is going to elucidate on, and to the proximal tympanic segment, which is here, and there's fistulization of the lateral semicircular canal, which is here. And I would say in conclusion, this looks like recurrent cholesteatoma. In this case, where they've had surgery, I might actually, depending on who's asked for it, recommend non-echoplanar DWI for further characterization. So, in summary, the learning, I think the critical things are history, examination, and age. And you should use those to really narrow your differential diagnosis. If you've not had trauma, if you've got middle ear soft tissue, it's usually inflammation, plus or minus cholesteatoma, rather than anything else. It could be a tumour, less likely. Check the long process of the incus. Middle ear anatomy, I think, is essential for giving an accurate report to your ENT surgeon. I think it will assist them in reading your report rather than just completely ignoring it. And if you need to give a proper site of pathology to allow your surgeon to properly look into the ear and avoid complications as well. And if you think additional imaging is going to be helpful, then you should advise it, most often post-contrast MRI head or CT angiogram. So thank you very much.